Dr. Ratna. Morning, ma'am.
Very good morning to one and all present here. I, Dr. Shipra, on the behalf of Special Interest Group Diabetes and Oral Care, our organizing committee, and the faculties and students of the Department of Periodontology, JSS Dental College and Hospital, welcome you all in today's webinar. Seeking the blessings of the Almighty and His Holiness, Sri Shivratri Deshikendra Mahaswamiji will virtually inaugurate our today's webinar by virtual lighting of the lamp and invocation song. Over to you, Dr. Sumu.
Shubham kurutvam kalyanam arogyam dhana sampada. Shubham kurutvam kalyanam arogyam dhana sampada. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Honorable dignitaries, teachers, and everyone present here, it's my immense pleasure to introduce our chief guest for today's program, Dr. Manjunath B. Sir. He's Registrar JSSDC&H. We are indeed privileged to have you with us, sir. I request Dr. Anita ma'am, the organizing secretary from the Department of Periodontology, to welcome our chief guest for today's webinar.
Good morning, everyone. Namaste. With my sincere pranams to the Almighty and our Swamiji, Sri Shivratri Deshikendra Swamiji, I welcome Dr. Manjunath B, our chief guest for today's webinar. We are honored to have you, sir.
Thank you, madam.
Dr. Manjunath B completed his MBBS degree at JSS Medical College in the year 1989-94. MD Forensic Science from JNMC Belgaum 97 to 2000. He's been a leader, an administrator, an educator, and a physician by profession, persistently working towards the goals, missions, and visions of the organized structure of JSSDC&H. He consults at all stakeholders before making any decisions. It makes the academic and professional staff feel involved. With this cements the commitment to the organization, strategic vision combined with professional skills and expertise in resource management and credibility with the academic and research community. He guides JSS as a transformational leader. He's a confident and enthusiastic leader who believes in the importance of communication and working cooperatively to build positive relationship with staff and students. He's a strategic thinker, effective decision maker with a proven capacity to be innovative, response, who seeks opportunities and embraces change. This is a short list of all the achievements our Manjunath sir registered JSSDC&H. I welcome you, sir. I also welcome our speaker for today, Dr. Ratna and Dr. Sangeeta Deer, and our moderator, Dr. Bennett Fernandez, without whom this would have been incomplete and not happening at all. I welcome you, Dr. Ratna, Dr. Sangeeta Deer, and Dr. Bennett. I welcome our August gathering, the delegates, faculty, UGs, PGs, and dentists, and certain physicians from India, and periodontists from the Malaysian Society of Periodontology. I also welcome my SIG team, faculty of JSS, my department, my colleagues, and my technical team. Knowledge is power. I welcome you all to a powerful experience. Over to you, Dr. Shipra.
Thank you, ma'am. I request Manjunath sir to say a few words. Over to you, sir.
Thank you, madam. Seeking the blessings of His Holiness. I think it is a very commendable job that the special interest group is doing. India had the dubious distinction of being the diabetic capital of the world. Now I think marginally China has taken over and we are not far behind. And this requires a multidisciplinary approach. So everybody getting together, and this idea is a very unique one and good. And the activities conducted by SIG are really commendable. And this is one step in this regard. I would like to thank all the resource persons who will be contributing here, and I request all the delegates from India and Malaysia to please take advantage of this webinar. And I wish and I thank all the SIG members who have struggled hard and put in their efforts for the success of this webinar. Thank you. I wish them all the very best.
Thank you, sir. You never fail to encourage us. Thank you very much. I now request Dr. Maurya, sir, from the Department of Public Health Dentistry to give vote of thanks. Over to you, Maurya, sir.
With the blessings of the Almighty and His Holiness Swamiji, on behalf of our organizing committee and a special interest group team, I thank all the dignitaries of today's event, expressing my heartfelt gratitude to our patrons of JSS Academy of Higher Education and Research, Dr. Suresh B., Pro-Chancellor, Dr. Surinder Singh, Vice Chancellor, Dr. Kushalappa PA, Director, Academics, and our today's guest of honor, Dr. Manjunatha B., Registrar. I would also like to thank our keynote speakers, Dr. Sangeeta Deer, Dr. Ratna Devi, Vaithalingam, and also a special thanks to our chairperson, Dr. Bennett Fernandez, and also Dr. Shipra Rai for hosting today's event. Thank you all.
With that gratitude being expressed, thank you, sir. Thanks to the dignitaries and delegates for joining with us in this virtual inaugural program. We'll now start with our webinar. In this regard, I request Dr. Anita ma'am to introduce our chairperson for this webinar, Dr. Bennett.
Good morning, all. We now start with the scientific session. I'm proud to introduce Dr. Bennett Fernandez, who was my junior in JSS Dental College during his post-graduation. He graduated from KVG Dental College Hospital and Research Center, Sulia in 1999 and completed his master's in periodontics from JSS Dental College, Mysore. Recently, he also was awarded a PhD in medical and health professions from International Internship University, November 2021. He has more than 17 years of experience following his master's. He has completed his fellowship in lasers from the University of Genoa, Italy, associate fellowship in laser dentistry from World Clinical Laser Institute, USA. He has won 20 different awards and has published more than 35 papers in various indexed and peer-reviewed journals. He has been a guest speaker at various international conferences and webinars. He is a full member of the British Society of Periodontology and Implantology and many other periodontal societies. Also the Malaysian Society of Perio, Asia Pacific Society of Periodontology, and also the ISP BAP, and the founder member and mentor of ISPRP. He is also a member of many interdisciplinary societies worldwide. He has worked for over 11 years in India and currently is a faculty at SCGI University, Malaysia, since the past 6 years. I welcome you, Dr. Bernard Fernandez.
Thank you, Dr. Anita, for the warm introduction. And with the permission of the chair, can I introduce the first guest speaker of the day?
Please.
Okay, so it gives me immense pleasure to invite and also to have a brief CV introduction of Professor Dr. Ratna Devi. So she is currently a professor in Perio at the Faculty of Dentistry, University of Malaya in Malaysia. And she graduated from the University of Malaya with both a BDS degree and a specialist qualification, that is MClinDent in Perio. And she also worked in the Ministry of Health Malaysia and served as a consultant before joining the university for the academics, and started a career as a senior lecturer in 2008 and is currently a professor. So she has been a PI in various research projects pertaining to periodontal systemic relationships, genetic studies associated with periodontal diseases, perio-regenerative therapy. And on this note, I would like to say that she recently in 2012 also, she has one article with reference to today's talk on diabetes. And she was the only dentist, and you can say also the only periodontist from Malaysia in the 6th edition of the clinical practice guidelines, which has been practiced by the Malaysian, and it is also ratified by the Ministry of Health and the Diabetes Society and Endocrinology Society. So she is a really versatile person. In addition to her other roles and other clinical acumen in which she does the research on the periodontal regenerative. So research output has been published also in various WS, Scopus and other journals. She was previously the past president of the Malaysian Society of Perio in the year 2015, and is also a member of various national and international societies like the International Academy of Periodontology, USA. So she's an editorial board member of the journal also, of that journal, and also of the Journal of the Annals of Dentistry, University of Malaya. So she's presented many international seminars, okay, and locally also, basically on the perio and interrelated aspects. So with this introduction, I would like to hand over the stage, or rather we could call it the virtual platform, to Professor Dr. Ratna. Over to you, madam. Before we just proceed, I just have a few housekeeping rules. I request everyone to please see, especially if you're joining from their mobiles, to mute their mic so that it does not disturb both the speakers. Okay, and you can drop in your questions in the chat box. Thank you. Over to you, madam.
Okay. A very good morning. It's actually afternoon, going to be afternoon here. Anyway, it's a very good morning to everyone here. I'd like to thank the organizers for having invited me to present this very auspicious occasion. Thank you, Dr. Bennett, for your kind introduction. And I will, without wasting any further time, I will start my presentation. Can you hear me? Are you able
Yes,
to hear
ma'am.
me?
Yes,
Yes,
All right,
yes, yes.
okay. I need to get to, hang on here, let me take this out. Right. So you can see the screen.
Yes, ma'am.
Right. I seem to break this down further. Okay, so the topic that I'll be talking about today is periodontitis, diabetes continuum, Malaysian perspective. And I'm from the University of Malaya, as Dr. Bennett has mentioned. We are in Kuala Lumpur, Malaysia. So as okay. All right, so just for those who are not very familiar with where Malaysia is, I think you can see here, this is India, and we are this country that's here in green. So Malaysia, we've got West Malaysia and East Malaysia, and Kuala Lumpur, where I am in, is somewhere here in the middle. So we are surrounded by Indonesia, Singapore, Thailand. Malaysia is a country of multi-ethnicity. So we've got basically populations. The main population is the Malay group, the Malay ethnic group, which comprises about 60% of the population. And we've got the Chinese coming up with about 25%, and Indians coming in at about 10%. And the rest are made up of the indigenous groups in Malaysia. So this is the faculty that I work in, the main campus, and this is our dental faculty. And the faculty has been around. It's currently celebrating we are currently celebrating our 50 years of being in existence. So there are actually a lot of activities going on. So coming to our subject matter for this morning, periodontitis is, I think we all understand, it is a disease of the tooth supporting structures, and it has got a worldwide prevalence of 20 to 50% of the worldwide population. Out of this population, there is 11.2% who actually suffer from severe forms of the disease. And the most recent global burden of disease study that was conducted has reported severe periodontitis as being the 11th most prevalent disease globally. From the Malaysian perspective, the Malaysian government has a 10-yearly survey that they conduct. Unfortunately, the most recent survey was supposed to have been conducted in 2020, but because of the pandemic, it was postponed and is currently ongoing. So the findings from the 2010 survey has reported 48.5% of our population suffering from periodontitis, with a very high 18.2% suffering from severe periodontitis. So with regards to the clinical scenario, I'm sure you're all aware, the signs would be what you'd see in this picture, clinical signs of disease, of inflammation. And periodontitis has its main etiology being the bacterial the biofilm. And it's the host immunoinflammatory response that actually determines the progression of the disease. So this then leads to the destruction of the supporting structures of the teeth, and if not treated, it will end up with tooth loss. A very quick overview of the etiopathogenesis of periodontitis. So the microbial challenge comes from the biofilm, whereby the host response then triggered, and the cytokines, prostagionoids, MMPs, and the others that are released will then act on the connective tissue and bone metabolism, and that will be the result that we see in clinical signs of periodontal disease. So we have lifestyle factors such as diabetes, smoking, which will then impact on the disease progression. At the same time, genetic risk factors also come into play their role. So having said all this, we now understand that periodontitis has the presence of periodontitis-associated bacteria such as Porphyromonas gingivalis, Turnarella forsythia, Fusobacterium, Nucleatum, and many others in the deep periodontal pockets that we see here. So in this, we also, at the same time, we understand that this inflamed periodontal tissues are a rich source of pro-inflammatory mediators. So if we were to actually take a little biopsy of this inflamed tissue and look at it under the microscope, what we would see here is, just to orientate you, this is the tooth and this is the gingiva. You've got the underlying alveolar bone here, and there is this blood vessels that are sort of distributed in this area. So on the outside, you have the oral epithelium, and on the inner side, you have this very ulcerated pocket periodontal epithelium. So, these studies have shown that if you were to actually look at the cross-sectional area of this entire inflamed gingiva in a patient from a generalized severe periodontitis, you would find that the cross-sectional area would be in the range from 8 cm squared to about 20 cm squared. And that is quite a big area of inflamed ulcerated periodontium. And this would be, if you're looking at it, 20 cm square would be about the size of the palm of our hands. So this then leads us to look into the mechanisms for pathogenicity in the periodontitis systemic link. So what has been suggested is there is this hemogeneous spread of bacteria from the inflamed periodontium. The one that we were talking about, this ulcerated periodontal pocket, becomes a site for the migration of these periodontitis-associated bacteria that we mentioned, such as Phorophomonas gingivalis. They get into the tissues, they then get into the blood vessels that are present in the gingival tissues here, and they are then carried into the other parts of the body. So the circulating bacteria then gets access to organs at distant sites far away from the oral cavity, where they may cause their effects. So at the same time, there is the other method whereby there is a hemogeneous spread of inflammatory mediators. So as mentioned earlier, the periodontal lesion is a rich source of pro-inflammatory mediators that will get into the systemic circulation and increase the systemic load of inflammation. And this then becomes a contributing factor in the pathogenesis of other systemic diseases. So this will then bring about the link here between the infection and inflammation that's going on in the oral cavity that then gets carried out to all the other organs and systemic conditions. So this has brought about this link, a lot of associations that have been introduced over the past few decades. So diabetes and periodontal disease, and then you have got rheumatoid arthritis, cardiovascular disease, respiratory disease, and many, many more. So the term periodontal medicine was first proposed in 1996, and that actually talks about the periodontal systemic relationship. And 2 decades later, what we are seeing now, you actually find that there are more than 57 different systemic conditions being researched in relation to periodontitis. And this was what was reported in 2016. So it's 2022 now, so I'm sure the 57 has become very much more. So what is important to note is that most of these studies were observational studies. And we know that from observational studies, we can only generate associations and hypotheses, but we cannot show causality, unlike what we can see from experimental studies. So it's highly recommended that observational studies with compelling associations need to be further confirmed by robust experimental data. And this is because observational studies have limited value to inform of patient care and health policies. And what they have actually advised is that people who are doing researchers who are doing observational studies look into the Bradford Hill criteria and stroke statement, which is the strengthening the reporting of observational studies in epidemiology. All these needs to be looked into when you employ your methodology for publication of any periosystemic observational studies. So, to ensure this, what is this Bradford Bradford Hill criteria? It talks about biological plausibility, data consistency, specificity and coherence, proper temporal relationships, biological gradients, experimental reversibility, other similar biological precedents as well. And stroke statements talks about improved quality of study reporting, data sharing, transparency concerning what was planned and what was done, protocol publication and registration of the study. So the advice is that all these criteria needs to be looked into when we actually talk about perio-systemic study. Yeah? And the authors, Prof. Batol and Mariotti, what they have done is using a disease association checklist based on common risk markers and experimental data that defines the relationship. They looked at a series of perio-systemic relationship studies, such as diabetes, obesity, adverse pregnancy outcome, cardiovascular disease, osteoporosis, rheumatoid arthritis. And what they looked at was in terms of biological plausibility, strength of association, effect of periodontal treatment on disease condition, and effect of treatment of disease condition on periodontitis. And having looked at all these conditions, what they found was that it was only in diabetes that you have all the ticks marked. So it was a big yes for all the 4 areas. For the other systemic diseases, there are areas that are not there. There are areas which are emerging. But for rheumatoid arthritis, it's sort of getting there because you do have plausibility and strength of association, and there is a lot of emerging evidence with regards to treatment. So that brings us down to our topic today, periodontitis and diabetes link. So what is there in the literature? So we know that it's a two-way relationship. We know that diabetes becomes a risk factor for periodontitis, and at the same time, periodontitis is also a risk factor for diabetes. So we will look at it first from the diabetes as a risk factor for periodontitis. So this was initially used from large-scale studies on Pima Indians from South America. So these are a group of subjects who have extremely high prevalence of type 2 diabetes. So there were a lot of studies that were done on this group of Red Indians. So they found that severity of periodontitis was higher in individuals with uncontrolled diabetes than in those with no diabetes. And at the same time, the progression of periodontitis was also accelerated in these patients. Severity was also found to be greater in all ages, and it was also increasing with age. And similar findings have been reported in other subsequent studies. They have all found similar findings. And the pathogenic mechanism to explain this relationship is that diabetes, the hyperglycemia that's present in diabetes, which is also closely linked to obesity, whereby the adipose tissues become suppliers of adipokines. So together, diabetes, the hyperglycemia, in these patients, you have an increase in the advanced glycated end products, which then act on their receptors, and this interaction would then bring about an upregulation of cytokine production. At the same time, you have alterations in the neutrophil function and altered apoptosis of the cells. So collectively, all of these together will cause a dysregulation of the inflammatory response, resulting in an increase in pro-inflammatory cytokines and MMPs. And this will then become the contributing factor or a risk factor for the progression of periodontitis. So now we look at the other way around, how periodontitis becomes a risk factor for diabetes. So the presence of baseline periodontitis has been found to predict incident diabetes. Periodontitis adversely affects diabetes control, and severe periodontitis has been found to be associated with diabetic complications. So we look at the first one, periodontitis and incident diabetes. So this was introduced by Emma in 2008, whereby they found that baseline periodontal disease was independently able to predict incident diabetes over a mean of 17 years of follow-up. So what they did was they had 3 groups of patients, all with no diabetes at baseline, but the 3 groups had no periodontitis, mild periodontitis, or severe periodontitis. So at baseline, that was in the early 70s, none of them had diabetes. They followed these patients up over a period of 17 years, and at the end of 17 years, the odds ratio of developing diabetes was 1.5 for the no periodontitis group, 1.71 for the mild periodontitis group, and very much higher, 2.26 for the severe periodontitis group. So we actually have 2.26 times high risk of developing diabetes if you were in the severe periodontitis group. So next, we look at the relationship between severe periodontitis and type 2 diabetes. So studies have shown that severe periodontitis causes an increase in HbA1c levels of about 0.3%. And this is quite a significant level. And there is at the same time an increase in the risk of developing incident type 2 diabetes, as mentioned earlier, with an adjusted hazard ratio of 1.19 to 1.33. At the same time, severe periodontitis in the comorbid presence in type 2 diabetes of diabetic kidney disease has been shown to cause a 10-year all-cause mortality risk increase by 41%. And this is compared to 36% in the non-periodontitis group. And a 10-year cardiovascular mortality increase of 22% compared to 16% in the non-periodontitis group. So at the same time, patients with severe periodontitis with type 2 diabetes have also been found to have significant cardiovascular complication with an odds ratio of 2.2 to 2.6. So this sort of shows the link, that association that associates periodontitis going on to becoming a risk factor for diabetes progression. So with regards to the mechanism involved, the entry of oral microbial agents from periodontal disease and their viral inspectors and the pro-inflammatory cytokines into the circulation will result in an increased systemic inflammation. And there is also strong evidence of elevated levels of C-reactive proteins, other acute phase reactants, and raised biomarkers of oxidative stress. Okay, so all this goes to show us the presence of systemic inflammation, other systemic inflammation going on in these patients. So this increased systemic circulation from this periodontitis will impact on the pancreatic beta cell function and cause insulin resistance and the progression of type 2 diabetes or even the development of type 2 diabetes. And this impact can also be seen on the diabetic control and its complication. So this figure sort of shows the cycle that we see in these two processes. So how type 2 diabetes is through the presence of all its pro-inflammatory mediators will then cause progression of periodontitis, and periodontitis by itself, because it's also a source for the systemic load of pro-inflammatory mediators, will impact and cause insulin resistance and progression of type 2 diabetes. So this association has been well recognized by the World Health Organization, and they have said that both are widespread conditions among the world's population, and the worry is that diabetes mellitus has an increased prevalence, which is constantly rising. So in 2018, there was about 415 million people worldwide having this disease, diabetes, whereas for periodontitis, again, the prevalence from the Western countries was about, it's from the whole world, around the world, it's about 750 million people with severe forms of disease. So when we look at it from the Malaysian population, sorry, I don't know whether you all can see this, but for diabetes in Malaysia, it's 18.3% of our adult population, or 18 and above, having diabetes. And for periodontitis, as I mentioned earlier, 18.2% suffer from severe forms of the disease.
It is visible, madam.
Okay, thank you. So, so we did this little study in Malaysia, where we looked at periodontal status and oral health knowledge among a selected population of Malaysian type 2 diabetics. And what we found was that 55.3% of the diabetic subjects in this selected group had periodontal disease, and 18.1% of these subjects had severe periodontal disease. So the diabetic subjects who actually had advanced periodontal disease were more likely to be taking a combination of both oral antibiotic drugs as well as insulin. So they were actually on higher stronger medications compared to counterparts. Among the diabetic subjects who had periodontal disease, what we found was that only 27% of the subjects believed that diabetes had some influence on their health status. So this is worrying because it sort of shows that there is such a lack of awareness among these patients as to this association and what's happening in the body and how they can actually use that understanding to go about helping their management of diabetes. So what is the importance of periodontal therapy in diabetic patients? So periodontal therapy will reduce the systemic load of inflammatory mediators present, therefore reducing insulin resistance, and an improvement in glycemic control is also seen. And this is done by performing oral hygiene, professional mechanical debridement, which comprises oral hygiene instruction and motivation, full mouth periodontal debridement, and regular re-evaluations. And those who are on maintenance therapy should be regularly reviewed. So this is always done in conjunction with sustained home care. So that's the understanding that the patients need to also be given, that they need to have this, on their part, what do they do? So the effect on this periodontal therapy in our little cycle that we showed earlier, by performing periodontal treatment, we are able to cut off this whole part of the cycle. So you are actually breaking this vicious cycle that you see, and therefore you do not have so much of an impact on the insulin resistance and control of diabetes. So with regards to periodontal therapy, we also did this study looking at the effect of non-surgical periodontal therapy versus oral hygiene instructions on type 2 diabetes subjects with periodontitis. And this was a randomized clinical trial. This was done sometime back in 2014. So we had two groups of patients. The test group was given non-surgical periodontal therapy. The control group, due to ethical reasons, we were not able to keep this group untreated. So this group was given oral hygiene instructions. And at baseline, we followed these patients over a period of 3 months. So at baseline, there was no real difference between the two groups. But what we found was at 3 months of therapy, the test group that had received non-surgical therapy found there was actually a significant reduction in the HbA1c levels. And this finding has also been consistently reported in many other randomized controlled clinical trials. And a series of systematic reviews of RCTs have been done over the years. And what they have shown is that the reduction in glycated hemoglobin levels have been also reportedly in that range of between 0.3 to about 0.5%. So by performing periodontal therapy, the management of doing periodontal therapy, we are actually, we know definitely that periodontal therapy will improve clinical periodontal parameters. And this also happens in poorly controlled type 2 diabetics. So the advice that has been given to us by the endocrinologists in Malaysia is that it's safe to perform non-surgical periodontal therapy in your periodontitis patients, even as long as the range of their, their random glucose levels are up to 16 millimoles per liter. So if they are less than 16, it's safe to go ahead and do your non-surgical periodontal therapy, knowing that it's actually going to help them with their diabetic control. So by performing this, we know now that it's going to reduce the HbA1c levels range of between 0.3 to 0.5%. And all this will happen without the need for the adjunctive use of antibiotics. So just by performing scaling and root surface debridement, we are able to reduce this HbA1c. This is good because we do not need to have this indiscriminate use of antibiotics, which again would end up with antibiotics resistance and all the other problems. So this then has brought about the need, as the importance of having a very good referral program, between the healthcare professionals and the oral healthcare professionals, whereby the healthcare providers, they perform routine referrals for oral healthcare as part of the holistic care. And from the oral healthcare side, the oral healthcare providers work closely, collaborating with physicians and other oral healthcare providers for improving the glycemic control of their patients. So having said this, and this is what we see in very most journal articles that have been looking at this link. So what we wondered was what is actually happening in Malaysia. So was it something that is being done among the dental professionals? Most of our oral healthcare professionals are very much aware of this association. However, we wanted to sort of look into the knowledge, awareness, knowledge, attitudes, and practices on the management of diabetes mellitus patients with periodontitis amongst the Malaysian primary care practitioners. So we actually did this study to see in Malaysia, the diabetic patients are generally managed in the healthcare system of the country, whereby they get their treatment under the primary care practitioners, medical practitioners. So they are treated by family medicine specialists who, together with their medical doctors who are working under them, together they work and they treat these diabetic patients. So the majority of our patients go through this pathway in their management of diabetes. So we send this questionnaire to the 5 states in Malaysia, the 5 highest states with diabetes. The practitioners in these states were given the questionnaires. So we sent out more than 750 questionnaires, and we got back nearly 500 plus questionnaires. So we got a good response from the medical practitioners here. So what we found out was that medical practitioners had good knowledge of periodontal disease. They all knew what it was and they understood what it was. But the majority of medical practitioners, that was 83% of them, claimed that it was not their responsibility to examine their patients for periodontal disease. So this is what they, now this is basically what they felt. And most medical practitioners did not inquire about periodontal disease from their diabetic patients. So there was completely no communication with their patients about the disease. More of the family medicine specialists, so those are the specialists who are in charge of these clinics, so more of them referred patients to dentists compared to the medical doctors who are under them. And when we asked them, we looked into the barriers faced during the management of diabetic patients. Majority of them said that it was because of patient refusal. So again, this sort of reflects on the awareness that the patients are having with regards to this knowledge. Obviously, they are not very aware of the relationship, and they are not aware of what happens by actually getting periodontal therapy and how it actually helps with their management of diabetes. So that's lacking here. So the other barriers faced by the medical professionals were that they said that it was also adding on to their workload. There was time constraints to write referral letters, the dental clinic location being not too close, and the complex referral system that was there. But what was interesting was that quite a few of them, about nearly 20% of them, found that oral healthcare, they actually said that oral healthcare is not part of diabetes management, which is in their clinical practice guidelines that is been advocated for all the medical health professionals. And because it's not in their CPG or clinical practice guidelines, so they are not doing it. So in Malaysia, we have set quite a few clinical practice guidelines which have been created for different various diseases, and for diabetes, it has got its own guideline. And the medical practitioners, basically, when they treat the patients, they are actually asked to follow very closely the clinical practice guidelines in the management of the disease. So what we actually recommended is that information on management of diabetic patients with periodontal disease should be incorporated in the Malaysian clinical practice guidelines on management of type 2 diabetes. And we were very lucky because at that time, the 6th edition of the CPG was coming about. And we were finally, there was some awareness being passed on to the endocrinologists, and they actually finally decided to invite us in to be part of the 6th edition of the CPG. So this CPG was launched on the 30th of January 2021, and the CPGs are actually reviewed every 5 years. So the next review would be in 2025, or even sooner if there's new evidence becoming available. So the objectives of these guidelines is to provide evidence-based recommendation to assist healthcare providers in the identification, diagnosis, and management of patients with type 2 diabetes. And in the forward by the Director General of Health of Malaysia, he has mentioned that in this network age, we should no longer be working in silos, and he would like to reaffirm the importance and recognition of a multidisciplinary approach in managing type 2 diabetes. And so they then came up with developing this guidelines. So in the development, the relevant experts from different specialties, not just endocrinologists, but they had specialists from, they had nephrologists, neurologists, gastroenterologists, hepatologists, cardiologists, ophthalmologists, psychiatrists, pharmacists, diabetes educators, and also dental surgeons. So a periodontist was asked to come in to be part of the guideline development. So they used the 5th edition as their basis, and they came up with a list of clinical questions, and this was divided into different subgroups with task forces. Members of each task force was assigned a topic. And the task force then looked into the literature, retrieved all the relevant literature, and this was critically appraised and discussed during group meetings. And they then came up with statements and recommendations by the task force members. So this brought about the draft guideline, which was then submitted to external reviewers. And finally, the final product was presented to the committee that was overseeing the CPGs and for approval. So with regards to the clinical question that was given where periodontal disease came, the question was, how does periodontal disease affect management of type 2 diabetes and how can it best be managed? So from the findings of the nationwide findings, there is definitely an increase in the prevalence of type 2 diabetes, which has happened over the past few years. So as shown here, in 2015, the National Health Morbidity Survey has found that collectively overall diabetes prevalence in adults above 18 years was 13.4, but this has risen to 18.3 in 2019. And when looking at further details, the other worrying factor was that we see younger and younger patients coming up with diabetes. So 18 to 19 age group, 4.3% of the overall diabetes population, and 20 to 24 age group made up 5.4% of the overall diabetes population. So you can see that patients, the subjects less than 25, there is about 10, makes up about 10% of the overall diabetes population. And we looked at in terms of ethnicity. So we had the different ethnic groups, and the Indian population here, the Indian ethnic group of Malaysians made up the highest number in terms of percentage, 31.4% of the overall diabetes population. So this has actually then brought about the importance of a team approach in managing this patient. So patient-centered comprehensive care requires a multidisciplinary team of healthcare providers. And so this actually gives a lot of benefit to the patients, because when working with healthcare providers with different skills and specialties, this allows the patient to gain in-depth knowledge and understanding of their diabetic condition. The patient's needs are addressed. It avoids therapeutic inertia. It prioritizes timely and appropriate intensification of lifestyle and or pharmacological therapy. So the emphasis here is on a multidisciplinary team approach in managing this type 2 diabetes. So the team members would then comprise diabetes educators, dietitians, registered nurses, and assistant medical officers. That's a group that is in Malaysia. These are a group of professionals who assist medical doctors in the management of patients. Physicians, endocrinologists, diabetologists, pharmacists, ophthalmologists, optometrists, and also oral health professionals. So these all together comprise the team members who will be managing type 2 diabetes in each center. So the target for control that has been recommended is HbA1c of less than 7 for most, but a much stricter level of 6.5 is advocated for patients with a shorter duration of type 2 diabetes who have no evidence of significant cardiovascular disease and longer life expectancy, and also are not in the danger of becoming a hypoglycemic patient. So in these guidelines, we come under the section on management of chronic complications, where you have all the different complications: retinopathy, diabetic kidney disease, neuropathy, cardiovascular disease, diabetic foot, sexual dysfunction, mental health issues, and also periodontal disease. So what has been a summary of the updates that were given? It has been emphasized that oral health education should be provided to all patients with type 2 diabetes, emphasizing the increased risk of periodontal disease in type 2 diabetes. And this should include the bidirectional relationship of periodontal disease and type 2 diabetes, adverse effects on HbA1c control due to untreated periodontal disease. The successful management of periodontal disease will improve metabolic parameters. Same time, there's also update on the direct relationship between periodontitis and cardiorenal complications of type 2 diabetes. So type 2 diabetes patients with periodontitis have been found to have an increased cardiovascular mortality and morbidity, and also those patients with diabetic kidney disease. So following up on this CPGs, the recommendations that were given for all these health professionals was that all oral health education should be provided to all patients with type 2 diabetes, emphasizing on this increased risk, and successful management of periodontal disease will improve metabolic parameters. So physicians, medical health professionals should investigate the presence of periodontal disease as an integral part of type 2 diabetes care visits, and if present, prompt referral should be made to the dentist for periodontal examination. And for all people with newly diagnosed diabetes, referral for a periodontal examination should occur as part of the management. Even if no periodontitis is diagnosed initially, annual periodontal review is recommended. And following this, once this CPG was launched in January last year, following this launch, we have actually seen very much increase in the number of diabetic patients who are actually being referred for periodontal care. And this is actually a positive sign that we see with regards to this. So this, as mentioned, this CPG was launched in January 2021, and it was done nationwide. And what they have used for promoting the new components of the CPG is they talk about the less spoken of diabetes and periodontal disease. And this was also then presented during that launch. Following the launch, the ministry has actually come up with a series of rollout of the CPGs, which was conducted as webinars, which started sometime in December last year and is going to go on until February this year. So this is basically to bring about awareness to all the medical practitioners, medical health professionals who are managing diabetes patients nationwide, and it comprises sort of overview. So we had periodontal disease was brought into one of the webinars that they had, that was the third webinar. So it was talking about the different associations, and there was case discussions and Q&A, and this was basically to help the medical health professionals understand the complications that are associated with diabetes. And there was actually quite a lot of questions from the medical health professionals with regards to diabetes. I think they probably have heard a lot about coronary artery disease and retinopathy. So with regards to periodontal disease, it's something new for them, and there was actually a lot of questions from them. So, so with that, I'd like to sort of conclude by saying that, this whole flow that we've had this past few years has actually helped us a lot, because when we have actually been seeing a lot of times when we actually speak to the medical doctors, when we try and give talks, the acceptance may not be so absolute. They take it and they may not really follow it. But what we find that it's now coming from their medical healthcare professional, it's coming from their authority. So the message would definitely be taken and dealt with in more details. Yeah. So with that conclusion, I'd like to conclude with the fact that the inflammatory link between periodontitis and type 2 diabetes emphasizes the important role that physicians and dentists play in managing both conditions. And prevention, as we know, is the key for oral health and general health. So prevention should be tailored to individual needs through diagnosis and risk profiling. And to sum it all, this was given by the Surgeon General of USA. I think it was way back in 2010. So good oral health and general health are inseparable, and that's what he has mentioned. So that I'd like to thank you for your kind attention, and
so thank you, Prof. Ratna, for that really, I can say a really fantastic lecture and webinar where you covered from the basics to understanding what is the perspective in Malaysia. So I would like to take up a few questions which have cropped up. Some you did cover in your lecture, but maybe you want to throw one or two key points or take-home messages. So the first question is, does diabetes increase the risk of periodontitis?
Yes, it does. I think I did mention it in my lecture where, diabetes has been shown to increase it's a risk factor for periodontitis. So we know that that's quite well established, that because of all the inflammatory mediators that are present in the patients with diabetes, they've got this dysregulated inflammatory process, and you have an increase in all the pro-inflammatory mediators, TNF-alpha, interleukin-1 and 6, and all the rest. So all that is increased, and that would then impact on your periodontal disease as well. So to actually hasten to further the progression of periodontitis. So it definitely does have an impact.
Okay, thank you for that answer. Another question is, how will I know if I have any mouth problems associated with diabetes, or even if we check the oral cavity, what should we look at? This is basically like, maybe as a periodontist we might understand, but like if some other a general dentist, or what should we see for the signs and problems which are there in the oral cavity?
Right. So for periodontal disease, the cardinal sign would be bleeding. So that would be the first sign that something is happening. So you see bleeding gums. It's such a silent. Periodontal disease is actually a very, very silent disease. You don't even realize it's there because you just see some bleeding in the mouth. When you're brushing, maybe you have a little bit of bleeding and you just ignore it. You think it'll go away. Sometimes it does. But if you do see signs of bleeding, that's the initial sign. If you do some, if you attend to it fast, you get it reversed and it will be fine. But if it's left unattended, it will then progress, and you'll see the other signs of inflammation, which would be swelling of the gums, and then you'll see everything becoming very red and very fiery, and you may occasionally even have abscesses on the gums. So these would be the other signs of periodontitis that you may actually see in yourself or your patients. And your patients themselves may actually then complain of their teeth becoming shaky, So that once the teeth becomes shaky, that's already progressed much further. It's at a more advanced stage because they've actually lost structure attachment structures, and ultimately if the patient says that your patient, when you ask them and they say, I keep losing my teeth because it becomes so shaky and ultimately it just drops off by itself, or I can even remove it by itself. So that is the other sign of a very advanced periodontal disease.
Okay, thank you. Thank you. Yeah, I think that's very lucid and clear, especially if there are some undergrads listening. I think it's something which they should really listen to in this modern day age. Okay, there's another question. So can I get a dental implant to replace a missing tooth, even if I have diabetes? Or like we hear, right, people with diabetes have a higher risk for gum disease. So can you just a little bit elaborate, though you have already covered some of it, more on the implant aspect also?
So with regards to implant, I think if you look at the evidence, there's very strong evidence to say that if you are a patient with periodontitis, implant is not a thing that you should look at until you get your your periodontal disease treated. However, if you are already treated, you're a former patient of periodontitis, you have now got everything under control, then it's not a contraindication. You can get your implant done, but it is with a lot of caution. So you need to make sure the patients are followed through regularly, they come for their follow-ups. With regards to diabetes, again, the latest evidence does not actually show any strong evidence to contraindicate it, but we would actually look more towards diabetes being a risk factor for periodontitis, and we'd like to make sure the patients also well controlled with regards to diabetes before putting our implants in.
Okay. And I think you had, maybe you can just once again just highlight, you've answered this question in your slides. What is the the effect of the periodontal treatment on the diabetes control? What is that percentage you had mentioned very beautifully? So you can just maybe highlight again.
Okay, so lots and lots of clinical trials have been done. So based on all these clinical trials, systematic reviews have also been done with meta-analysis. And we know that in the hierarchy of evidence, this is the highest level. Systematic reviews actually come at the highest level, and they have reported the improvement in the range of between 0.3 to about 0.5% reduction in HbA1c level. So if you have a patient who has got a HbA1c of, say, 7.5, so by doing your periodontal therapy, the improvement in the short-term period would be a reduction from 7.5 to 7, which is very much better and probably within the control group in certain groups, or between a 7 and a 6.5. So again, this is what we would want, and this would actually prevent the need for the medical practitioners from having to give another, a much stronger medication for their patients. They may not need to have to do that by just you coming and getting your patients to get their periodontal treatment looked into. So that would be our advice to the patients.
Okay, and now that we are in the COVID or post-COVID, or I do not know, whichever era, so can you just tell about the post-COVID patient and who's having diabetes, and I mean he has recovered from his COVID, and anything to do, any extra precaution or any extra care or anything in particular with regard to the periodontal disease and the destruction per se, other than the normal protocols, or your take on the matter? Like,
okay, I think with regards to if you're talking about long COVID or post-COVID,
yes.
Well, I think the studies have actually shown, there have been studies looking into the effect of COVID and periodontal disease, and they actually found that there may be some association where periodontal disease can actually exacerbate the COVID infection. So the answer for all this is always prevention. So you do your best to actually prevent this condition. And if your patients have gone through it and they've gone through the long COVID, as long as you're following all the SOPs and in terms of infection control, there's no real contraindication to stop you from continuing with the periodontal management. So please do go ahead and get your patients treated.
Okay, so I guess we have covered all the questions. If anybody else would like to ask any more questions, please, I'll just have one more look if anything in particular. Yeah, I think it's you have covered everything, madam. So yeah, I think yes, we are done. So Dr. Anita, you would like to say something or anything in particular?
Nothing. I think Dr. Ratna has given an overall picture of about diabetes and about periodontitis and the interlink between both sides, diabetes to periodiabetes. And I think she's rightly stressed on the interdisciplinary approach where periodontists are also tagged into that treatment protocol of the patient, because normally they have the dietitian, they have the physician, they have the endocrinologist. She has rightly stressed, and I think she's done a commendable job there in Malaysia of meeting or getting the health ministry to actually recognize us and the essentiality of periodontists for diabetes patients. So rightly said, ma'am, interdisciplinary approach. So we are all in.
Thank you. And I think that's a steep challenge for all of us because
I totally agree.
Yeah, thank you.
Thank you, ma'am. Thank you for the time and your excellent presentation. I thank Dr. Ratna Devi Vaithalingam for her expensive time. Time is precious, isn't it? I've been trying for quite some time to get her into our group. Thank you so much, ma'am. Please accept this certificate of appreciation from our university.
Thank you very much. And thank you for the honor of giving this little talk to be shared with all of you. Thank you so much.
Honored to have you, ma'am. I take this opportunity to thank Dr. Farah, who is the Secretary of MSP, for giving me the backup of reaching out to the Malaysian Society of Periodontists. Thank you so much. Thank you, Dr. Ratna and the MSP for joining us.
Thank you.
So, Dr. Anita, do we move on to our next speaker for the day?
Do we need a break? No need, right? We can just start.
I guess we can go. So we are in the flow of the thing, and I think it's good enough.
Yeah.
So it gives me immense pleasure to talk about our next speaker for the day. And Dr. Professor Ratna has started the ball rolling by talking about the Malaysian perspective. And I think a very important person now here and well-loved periodontist known by many in India, being part of the Indian Society of Periodontology, Dr. Sangeeta Dev. So she did a master's in perio from the College of Dental Sciences, Davangere, and she has also done a clinical externship program in implantology from the University of Birmingham, United Kingdom. So she has been awarded the fellowship of the International Congress of Oral Implantology, FICOI. She is a consultant, that is dentistry and clinical research at Max Hospitals, New Delhi, and she also owns a multi-speciality private practice. Fulfilling her roles in the Indian Society of Periodontology, she has been the ex-vice president, and more importantly, the role, and which is of importance for today, the national convener as a prenatal periodontal healthcare committee to, as rightly mentioned, about the systemic link, and is also currently the EC member of the Indian Society of Periodontology. She has numerous research publications to her credit and has been a keynote and guest speaker at several dental and medical conferences and meetings. And why exactly is that her important role in which, along with the collaboration of the Research Society for the Study of Diabetes in India, RSSDI, she held a landmark meeting on the 8th of September in 2019 in New Delhi, in which more than 150 delegates deliberated about this Perio-Diabetes symposium. And she has got numerous other publications other than the fact that it is published in the Journal of Indian Society of Periodontology. So with this, I hand over the virtual stage to you, Professor Dr. Sangeeta Dev. Madam.
Good morning, everyone. Please confirm if I'm audible.
Yes, ma'am.
Okay, at the outset, I would thank the JSS group in per se, I would say, and in inviting this platform today. And I must say that it's interdisciplinary when we talk about in our profession. It goes a long way when we talk about cross disciplines, and it further lands up into a bigger domain when we talk about cross country. So I think that's a giant leap. Dr. Anita, thank you so much, ma'am, and Dr. Ravindran, Dr. Deepika, ma'am. I've not met you guys, but yeah, it's some fora. Definitely, I would love to catch up with you. And thank you, Dr. Bennett, for this marvelous introduction. Not much needed, but it's take a little bit something or the other we all keep on doing at our ends. Okay, allow me to share the screen now. Is this there on the screen? Please confirm.
Not yet, madam.
Okay, hang on. Always get stuck in some glitches. 1 second. Okay, now I think I need a 1 second. Hang on.
Ma'am, please, yeah. Now I
Is
think, yeah, it is.
Yes.
It's there?
Yes, ma'am.
It
Okay.
is.
Okay, now there we are, a brief intro of mine. Now my just journey of this perio crosslinks, apparently I think in India we have just witnessed it for the past 5 to 8 years. I think there's a huge upsurge. And what better example I must quote here is, today we are talking about a specialty group committed to this particular topic. And that's a big leap, I must say, and hats off to JSS Dental College on the subject. Moving on, Dr. Ratna has beautifully captured the basics, and I would not bore the audience out here in terms of repeating it, but yes, it's always mandatory to take a bit of a recipe, going back to the basics and understanding what is happening in terms of the linkages. We are also talking a brief outline of what is happening in the diabetic mouth. I understand there are postgrads and undergrad participants as well. We are also talking about, apart from diabetes, what is the importance of the non-diabetic and pre-diabetic as far as the clinical scenario is concerned. We would be also touching on a bit on the impact on the glycemic levels. And further on, what I've understood in all these years is we always keep.
Now, 2019 study speaks to us as the prevalence of periodontal diseases only amongst the diabetics in India. It's about to the tune of 87%, where the gingivitis is about 28% and periodontitis, we understand, is about 60%. Complete tooth loss has been shown to us as about 11%. Moving ahead, what is the mechanistic links? Dr. Ratna has already thrown a light on the subject. Let me just take a quick review on the pages. We are understanding there's a concept model that had evolved, which we had somewhere around as a risk factors which are associated, which is finally going to be leading to some level of insulin resistance. Pathogenic mechanisms, we are understanding the glucocentric pathology and the etiology, and we do have something known as a lipocentric etiology, where the adipokines have got a prominent role to play as far as the biomechanics are concerned. This particular pictorial we are well versed with. How does the diabetes leads to periodontitis? There is a cascade of events. There is an OPG axis, there is a rage axis, there is an oxidative stress. Then here comes the role of the adipokines. And finally, they are going to be leading to a enhanced tissue destruction, impaired tissue repair, and finally a full-blown case of a periodontitis. Okay, moving on with the evidence-based mechanistic links. That's the concept model we were talking about amongst the shared risk factors, the pathogenic mechanisms, the lipocentric etiology, which has evolved over the years. Moving on to the risk axis schematic, which is talking about your age range axis, which is talking about your Rankel OPG axis, and finally leading to periodontitis. The adipocentric etiology is more or less again talking about the inflammatory concatenation of the events, leading to a compromised host immune response, leading to an increased hypoglycemia, and finally calling upon to periodontitis. How does a periodontitis impact the obesity factors? Similar mechanics in a reversed manner. It is going to be leading to an increased insulin resistance, hyperinsulinemia, and finally leading to obesity high rise. Now, potential pathways we have already understood. Increased in the HbA1c levels is going to lead to increased diabetic complications when it is triggering from the periodontitis. This is the same thing in a different manner with the newest components of your osteoclast and your dysbiotic conditions coming in. Now, moving on to what is the changes that we see at the clinical level. All said and done in the research and clinical academic level, we are fine. What we are doing is coming to the clinical scenario. It is important for we to understand as well as medical counterparts to understand what are the changes that is going to be happening in a diabetic mouth. To begin with, there is a cascade of events that happen. It initiates as a bacterial or fungal infections, a delayed wound healing, salivary dysfunction, taste impairment, burning mouth syndrome, cavity on a high rise, tongue abnormalities, halitosis, dry socket, and finally, gingival and periodontal conditions. Why it is happening? A, there is an immune dysfunction in a predominantly diabetic patient, which is going to be leading to oral changes. There is a side effect of drugs, which is going to be also coming into picture, which is going to be leading to a low salivary flow leading to an oral thrush. It is also because of the peripheral neuropathy, which is going to be leading to a cascade of events and finally a full-blown oral changes that we see in the mouth apart from the periodontal conditions. That's an average diabetic mouth, a normal condition, which could be predisposing to a gingivitis level. It could be as bad as the periodontal changes. A dental-stomatitis, the way it looks, a candidiasis, as well as a glossitis. That could be our friendly mouth that we see day in, day out in a diabetic patient. And that could be a lichen planus as well. So that's what we see in a schematic. Could be a red swollen gums, a longer looking teeth from a normal levels, increased spacing in the teeth, bleeding from the gums, bad breath, calculus around your teeth, and so on and so forth. So coming to the next question. Is it a diabetic only important, or do we need to understand unknown diabetic and the pre-diabetic patients as well? What is the important contribution that these two conditions have to say in today's times? Now, we are understanding periodontitis has an early sign of diabetes mellitus. There is an early intervention for pre-diabetes. Pre-diabetes, we are aware it should fall in the range of about a 5. Every time there is a revised, guidelines for pre-diabetic conditions. So Asian diabetic following is somewhere to the tune of about a 5.1 to about a 5.4. That's a pre-diabetic current regime. Early diagnosis and treatment of a pre-diabetes benefits the treatment of periodontitis. That's the reason why I need to look for the pre-diabetic patients. And the dental office, the study has shown in as a suitable location to track the pre-diabetic patient or a suspected new diabetes cases. What is the prevalence if we talk about the Indian scenario? So this was one ICMR funded, 2017, this was published as a paper. It was a study that was taken out in the 15 states in the country. And it talked about, what did it speak about? It was talking about a 7.3 prevalence rate. Overall, the prevalence of pre-diabetes in all the 15 states were about to the tune of 10.3%. And it's pretty high from the normal diabetic patient. Moving on, it's a prominent study, SHIP study. They had a database of about 4 years, 28 to about 2012. What they were talking about is, let's look at the graph here, first of all. The prevalence is on the vertical axis and the age group is defined in the horizontal axis. The strong bold line that we are seeing is the line that tells us about your A1C levels. The blue line that we are seeing talks us about the periodontitis level. Let us see what is the correlation between these two lines. It tells us that the pre-diabetes sets in by the age of about 40 and it's predominantly coinciding at this age bar. However, all said and done, the A1C is always on a high rise in the other age groups. Now, systematic review tells us that the undiagnosed type 2 diabetes mellitus is to the tune of about 11.2% and a pre-diabetic is about 48%. That's alarming percentages that we see. So a significant proportion of dental patients can be identified as undiagnosed type 2 and a pre-diabetes and a targeted opportunity screening is feasible when we talk about our dental setups. Impact on the glycemic control. There's abundant of literature available. If we Google surf, lot has been done as far as the periodontal intervention is concerned. Let us see the two sides. If we are leaving a periodontitis unattended, it is going to anyway lead to elevated levels of your HbA1c and finally increase the diabetic complications that we are aware. However, if we interject and provide a dental treatment or a periodontal treatment, to be very specific, it is going to reduce the circulating bacteria and the antigens. It is going to reduce your systemic inflammatory burden, and finally it is going to improve the insulin signaling and the resistance. This all is going to boil down to a decreased level of your diabetic complications. Studies, intervention studies, lot many are there. Now let me just hop upon this particular study, which is a systematic effect of the periodontitis in the type 2 diabetes. It's a 12-month study what they had undertaken. 2018 was a publishing year. They had compared a controlled periodontal therapy, which is a scaling and a root plane, to an intensive periodontal therapy, which is a surgical intervention. That it reduced the HbA1c levels, okay, in the type 2 diabetes after about 12 months. And what they suggested was a routine oral health assessments and treatment of periodontitis is an important tool for an effective management of the type 2 diabetes patients. Moving on, 2017 was a publishing year. Again, this was a cross-section of the systematic reviews published where they had compared the non-surgical periodontal therapy with and without your antibiotics. What they found over the protocol over the years was the average reduction was 0.4 at about 3 months. And finally, they also zeroed down to the clinical significant effects on the systemic health does play a role, and an adjunctive role of antibiotics doesn't really add much to the impact that the independent SRP is going to be undertaken. 2020, a prominent study again, which tells us that over the years, the average reduction which was seen, what they did was apparently was an active treatment was done at 2 months, where the bleeding scores and the mean bleeding scores and bleeding on probing and pocket depths were significantly reduced as compared to the baseline. Further, they found was a 1.3% reduction in the HbA1c levels, and a control of periodontal level of inflammation was seen active and reduced at about 12 months time. However, this all is fine in clinical research. When we talk to the clinicians, they are just not bothered about what is this 1, what is this 0.3. They would not look upon that. They need some evidence-based answers, and evidence-based answers, no doubt, it is still there. But coming to the ground level of clinical scenario, do we really have the synergy between the medical and dental fraternity? Well, we say if this question was there, say about like 5 years, things were totally on a battleground. Nothing was there, and no one would be able to understand and convince each other. So, moving ahead. Why do we need the synergies? We need to understand. Importance of oral health in a diabetic management team is largely gone unnoticed by the diabetes care providers. Simple as that. Evidence was lacking over the years, so probably they were not bothered much. Primary care providers, we are understanding a fact that it's their domain, so they will be looking only and only about the diabetes management, and all said and done, the periodontal disease component or the oral health component was always left out. Oral health providers, are they really present in the diabetes management team? Well, now the things have taken a different toll, slowly, gradually in India as well. It wasn't there at all some couple of years back. And dentists possibly are well versed, maybe at their end. However, when it comes to the management team, they are not ever available to be seen at all. Why it is important to have a synergy? The diabetic patients and the dental patients, we are aware, they are not understanding their mouth and its importance of maintenance as when we have a sugar levels up, and what is the importance that we need to play in terms of maintaining our oral health. Moving on. What is this collaboration going to talk about? If at all it is, a beautiful paper 2011. What does it say? Better understanding is made available to both the parties. Control of hypoglycemia and the end organ damage is controllable. So a good communication between the physicians, endocrino, the dentist leads to an optimized diabetes and oral health management. So we are always talking about the management of periodontitis. We are also talking about the management of diabetes. Why not? It's our own forte. What happens when we prefix a term co-management? That's where the importance comes into picture. Unless we put into papers, nothing is going to be happening. There comes the evolution of the term, transdisciplines or interprofession. There's a little difference between the two terminologies, and we'll come to know what exactly is the difference. Begin with, there has been a guidelines for dental healthcare professionals. There has been a guidelines for medical physicians. This all has been cumulated over the years by International Diabetes Federation, European Federation of Periodontology, American Diabetes Association, American Dental Association. In this particular lead, ISP also has got a major role to play when it comes to guidelines and formulation of guidelines and the event that has been put up in terms of your evidence-based data. Now, talking about the transdiscipline, what is this transdiscipline? There is a term called primary care providers. There's a term called healthcare partners. What are these healthcare partners? These are the practitioners of all the healthcare disciplines, such as the physicians, assistants, the physician nurses, the nurse practitioners, diabetes educators, midwives, and the dietitians. This comprises of the transdiscipline practice. What is an interprofessional practice? It is talking about an overviewing and approach regarding dentistry and oral health, as well as a general health care as two separate professions. Moving on, what should be the interdisciplinary communications that should be happening? We are aware there is one side of the patient which is sitting with us. There is the other side of the practitioner which is sitting there, and we are sitting here in this center. So the tripod that is happening here. So there is a fine, delicate balance that is we as a dental professional have an important role to play. How? Inform the detrimental effects to the patient about both the conditions. Reporting of the medical history by the patient to the dental professional is compulsory. Further on, what is the dental professional going to be doing is inform about the periodontist, the blood sugar level, and reporting of the HbA1c level in terms of the patient report and records to the practitioner. Moving on from the practitioner end, a referral has to start from here to here. From here to here, we are still understanding there's a ample referrals happening. What is still lacking is from here to here. What is the influence of the co-management in this coexisting condition? It is a win-win situation. We understand that. Let us see what is this win-win situation. So when we are having a periodontitis and a diabetes mellitus in a coexisting conditions, we are going to be understanding that both the diseases are detrimentally going to affect each other. When we are going to undertake a periodontal treatment, finally it is going to be leading to an improved oral health or periodontal health, leading to a reduction in the HbA1c, and finally when it comes and boils down to the clinician's end or the physician's end, there will be less of a prescription and a less of a medication for the patient. So what are these guidelines that we are talking about? Guidelines are there for the medical physician, the diabetologist, the periodontist, and the clinical practice. Moving on to the screening tool of the patients. Now, when we talk about the screening tool, we understand and we keep talking to the physicians. They have saying that we don't have a dentist in our facility, neither do we have a dental office nearby. What is it that we can do in terms of diagnosing it? Well, we do not expect our patients from our patients to be sent across to them and they will be doing a periodontal diagnosis to us. But yes, we do have something known as a visual inspection tool. And what is that visual inspection tool is our two eyes. They can always look up for grossly cavitated teeth. They can always look for an oral thrush, which I think they do look for the candidiasis. They can always look up for signs of periodontal disease in the mouth, which could be as a loose or few teeth in the mouth, the bad breath, the swollen or spontaneously bleeding gums. There is something known as a self-reported oral health questionnaire, which is available on the CDC AP sites. There are few questions, 8-point questions are there, which can be told to the clinicians what exactly they can ask. And there's a pretty simple question. We'll talk about this SRH questionnaire in a little while. Now, moving on to the guidelines. Guidelines, we are understanding there are guidelines which are dedicated to the practitioners. There is dedicated to the dental health professionals as well. So what are these guidelines that we talk about? Inquiring about the periodontal disease from the patient. When we talk about the type 1 diabetic and the type 2 diabetic patients, we have to inform about the negative impact of the periodontitis on the metabolic control. This is from the physician's end. the positive outcomes of the periodontal treatment on metabolic control and diabetic complications. And this implies from all the three types of the diabetes that comes across. What are the signs and symptoms? Eating gums while brushing and eating, loose teeth and spacing teeth, oral malodor or abscesses in the mouth. Newly diagnosed diabetics need to be understood and asked about if no periodontitis has been detected. Still, they need to be put upon an annual periodontal review. Diabetics who have an extensive tooth loss should be encouraged to pursue dental rehabilitation to restore the adequate mastication for proper nutrition. Oral diabetic complications like dry mouth, fungal infection should be informed to the patient. The dentist and the physicians should have overviewing the diabetes management protocol prior to the oral intervention or surgeries to avoid any level of hypoglycemia and to consider its potential impact on the patient's ability to eat. What are these guidelines for dental health professionals for diabetes in clinical practice? A dental settings is an important area we all understand to screen the patients. Type 2 diabetes or a type 1 diabetes and refer them according to the physician. So it's crucial to identify the type 2 diabetes in the early stages, which we have already spoken about, an undiagnosed case and a type 2 diabetic, pre-diabetic conditions. When we talk about clinical practice, personally, I can definitely answer this with very great commitment that at least over in a month, the kind of referrals that we send across to the physician is somewhere to the tune of about 30 to 50%. So we are doing that regularly in our setups. What are the guidelines for the clinician, for dental practitioners? We need to understand a diabetic patient is going to be having a list of issues, a list of medications. Glycemic control should be optimum before we start our procedures. It is important for us to collect the appropriate medical history, highlight the type of diabetes they are suffering from, the duration of the diabetes, and the presence of any complications, if at all they have, which kind of medical therapies or diabetic therapies they are on. Are they also going to be having any sort of a concomitant therapies, which could be talking about the comorbid risk conditions they probably would be suffering from. It could be some sort of an anticoagulant, antiplatelet drug. So the comprehensive medical review of the medications is important from our end. We need to ask about their glycemic control. We need to ask about their last blood glucose check levels. We need to also ask them to bring a copy of the last HbA1c levels whenever they have checked. Education and counseling, what are we supposed to be doing, which we anyway do. Still, help them with their oral health manuals, categorize their risk association factors, tailor and customize the oral health regime based upon their maintenance levels, what the way we are maintaining, reinforce their oral hygiene regime. Moving on to, if they don't have any periodontal disease, then what do we do? Should we just let them go? Definitely not. Even if the periodontitis is not diagnosed initially, we should still put them on a preventive care regime and monitor them regularly for any periodontal changes, if at all it is happening. Moving on to typical questions, surgical interventions. Should we do it? Should we not do it? There has to be a proper regime that we need to follow. Patients who are on insulin or sulfonylureas or meglitinides should be consulted prior for the physician consent. Timing should be opted appropriately to plan a long surgical procedure. Meal timing should be adjusted. Possible change in the dosage or therapy, if need be, to reduce the risk of intraoperative hypoglycemia should be undertaken. When we talk about treating diabetic children and adolescents, annual oral screening for any signs of periodontal involvement and dental caries should be evaluated. We need to assess the patient's blood glucose level before the surgery to ascertain any jumps in the sugar levels. Short morning appointments is always preferable, and check the blood glucose level every 2 hours if the surgical procedure is lengthy. Moving on to diabetes check. Now we have reached an era where we need to, advance our armamentarium, basic diagnostics, which calls for introducing a point of care diagnostics into our clinical setups as well, which begins with the minimum glucometer. And we have already incorporated that for the past 5 years, and we're doing it regularly. How about like emergency care? Diabetics presenting with any sort of an acute oral or periodontal infections require prompt attention. Periodontal therapy, non-surgical periodontal therapy should be provided no matter what happens in a diabetic levels. Now moving on, we are aware, let us just summarize it, what we have understood. Hyperglycemia, it is not just presence of the diabetes that leads to hyperglycemia. There's a dose-dependent relationship between the glycemia and the periodontal destruction. Patients with diabetes are 3 times more likely to develop a gum disease. The control of diabetes is more complicated if it is having a comorbid condition, say for example, a periodontitis, and a well-controlled diabetes is less prone to periodontitis. Coming to the other side, healthy patients with periodontitis have a higher chance of developing pre-diabetes and diabetes. This is what we need to screen in our clinical scenario. People with severe periodontitis have an increased risk of developing type 2 diabetes. There are higher levels of insulin resistance in people with periodontitis. Periodontitis is significantly associated with poor glycemic control and high blood glucose levels, both in the people with diabetes and in those without the disease. Significant reduction, we are aware, has been seen in HbA1c level at 3 months in the literature. Now, coming to improvising and including of the dental care protocols, it is always there in the Western Front. Diabetes care standards, which they keep on publishing every year and revising 2021, we are seeing that there's a lot which has been incorporated as oral health component, referrals for initial care management, and so on and so forth. Now, this is one typical tool. Why I'm repeating this particular topic for concern is what kind of a tool that we can help our fellow clinicians. They always have this issue. We cannot refer. What do we do? This is what I'm talking about, the self-reported oral health care. Now, this is a study, basically, it's a very recent publication, 2019. What they have done is they have developed a non-invasive tool for periodontitis screening in medical care settings. What they have done is they have picked up a self-reported oral health form, combined it with the demographic profile that we always do. They've incorporated a salivary biomarker quick check oral salivas. Also, they have incorporated as a assessment of a clinical periodontal examination, which is a total periodontitis or a severe periodontitis, and segregated into 3 models. What are these 3 models? Model 1 talks about SROH assessment, the demographics, and the salivary biomarker assessment. Model 2 deletes the salivary biomarkers, contains the SROH and demographics, and model 3 comprises of only and only SROH. So what did they conclude? They concluded that the total and the severe periodontitis prediction models proved to be feasible and accurate. However, the screening tool only and only gives an indication. We still need to have a referral coming as far as the periodontal diagnosis is concerned by the clinicians or the physicians. This is the SROH form that I was talking about. What does it say? This is a very handy tool, and we have actually from our side shared this information to our fellow clinicians, and somewhere some of them have already incorporated in their clinical reporting programs. Now, what does it say? It talks about as question 1, gum disease. This is the simplest tool you can ask. A physician can easily ask, do you have a gum inflammation? Do you have a gum disease? How do you rate your teeth? Have you ever had any gum disease? Any treatment to be undertaken? Do you have any loose teeth in your mouth without an injury? Have you been told by a dentist ever you last visited that you have lost your bone around your teeth? The simplest words that can be asked. In the past 3 months, have you noticed a tooth which is looking a little differently, a little longer? Apart from the brushing with the toothbrush, how many times have you used your dental floss? Beyond that, are you using any mouthwash on a regular basis? That's a perioscreening.com. AAP has this tool. I mean, self-reported assessments. It gives a quick, a compliance level to the patient. I think that's a tool which can be shared with our fellow physicians as well. Coming to the topic, India on the global map. What is happening in 2022? Let's track the history back, a couple of years back, would you say? Now, before we do that, if we Google search, that's a screenshot which I've just taken. I don't know how many studies are going on. 3 lakh studies on Indian scenario. Periodontitis, diabetes, somewhere or the other. Could be observational, could be review papers, could be your intervention, and so on and so forth. If we change the search words, what is the awareness of periodontitis and diabetes in India? Still, we can see almost about a good volume of numbers running in 6 figures. Okay. Moving on. What is this picture talking about? Having said all said and done, somewhere down the line, 2019 was the first time that we were kind of, of course, the planning for this event actually had started in 2018. when we are talking on our ends, it's very easy to, counsel and give a lot of, words of wisdom to each other from the same fraternity. When it talks about traveling the different zone into a fraternity, which probably stands bone in contention when we talk about this topic. However, all said and done, we just took a giant leap and tried to speak out and reach out to our fellow fraternity, the Research Society of Periodontology. I mean, Periodontology, Research Society of Study of Diabetes in India, RSDI, it's a short form of that particular organization. What is their opinion and view if we have to collaborate on some sort of an event like this? However, there was a little resistance. Obviously, every organization, society have internal conflicts. Yeah, they would not agree so easily. Luckily, the chair in person sitting there was pretty much, I would say, dentally oriented. Perhaps his wife was a dentist, to be very frank. And the moment this proposal reached them, I mean, we were not expecting this quick response from them. Little bit of a counseling, and yes, they somehow got consented in hosting this national symposium. And that is how that 7-8 months passed off in hosting this event at Delhi. That also was a long story, and let's not brief on the subject too much on this. So this was the final outcome that you see here. That was the first publication that went out. And there was a sort of a small, soft consensus that we reached out, and what is being published in the JSP. That's a consensus document. So what did they talk about, and what did we kind of zero down to? They agreed that peri-diabetics and diabetics have a higher chance of developing periodontal disease. The causality of the oral microbiome and diabetes is still unproven, but it still leads to the presence of hyperglycemia. Underlying biological mechanisms mediate a negative impact on periodontitis, and finally lead to a poor control of the diabetic conditions. The chronic inflammatory states contributes to pathophysiology. Improving the diabetic control leads to a better control of diabetic complications and diabetic levels. Clinicians of the respective specialties fully acknowledge and understand the gravity of diabetes and its risk associated, and vice versa. So it's important to set in some clinical practice guidelines that should be developed with the respective societies in the time to come. So this was 2019. Moving on. What happens in 2020 was finally these two societies, our ISP and RSDI, they again combined together, and that came the first management guidelines as far as the good clinical practice guidelines as a joint venture. Moving on, 2022, we are also happy to share that there's another diabetes organization by the name of Diabetes India, which has finally kind of came out as a national group, put it like this, as a special interest group, just the way JSS has a group. We have also kind of, put all these people together. We understood that evolving a group on our own might be a lot of challenge for us to reach out to the correct community. So luckily these guys, some of them were a part of the national symposium. So they were pretty much impressed the way the things had mobilized. So they joined hands, and we finally put up a combined team of the diabetologist and the periodontist on board. So this is just a working committee, and the times to come, there's a lot of agendas on board, and we will be happy to have more of our fellow colleagues on board. So just to wind up the sessions, a small little of a contributions that we guys have over the years done. I'm happy that there's a close knit of clinical clinicians that I'm working with at the hospitals, at attachments. They are quite much motivated in undergoing all these studies. So that's the first study that was not the first study, yeah, one of the studies that got published in your Indian Journal of Endocrinology and Metabolism. Believe me, entering these journals is not easy. The kind of peer review that comes, it just took a year for us to let this paper out. Anyway, so what this study was, it was a epidemiology study. About 1,700 people, it was a control study where we found a diabetic and a non-diabetic percentages ratio to the tune of about 72% and a 27% in terms of periodontal prevalence. The uncontrolled diabetic HbA1c levels was elevated. And cardiovascular risk factors, important tool to understand here is it is not just about the HbA1c, it's the cardiometabolic risk factors that really plays the whole game. So finally, we concluded that clinical relevance of identifying such patients with poor glycemic control and periodontitis and harnessing the individual integrative approaches is important for the correct management of the metabolic conditions. That's the second paper again. in the Indian Heart Journal. Basically, we are trying to understand what are these cardiovascular risk parameters and glycemic levels associated with the type 2 diabetes patients suffering from periodontitis. Again, it finally said that the need for development and implementation of guidelines is important, not just for guidelines to be published. It is important to take it down to the clinical level. That's the biggest challenge. Because we understand that it is not about only talking and undertaking symposias and conferences and guidelines that come on. No, boiling down to the clinical level in our clinical practices and the practices of our fellow clinicians. Screening of the periodontitis, pre-diabetes, diabetes, and cardiovascular disease is important. Moving on next. I was fortunate enough to have this cross country. This is a huge 3 universities, and our center had participated in coming out with this predictive model. Was in 2019, this got published. This was again a data set about a 3,000 odd, retrospective pulling out of the data. It was zeroed down to the level that the age, gender, ethnicity, HbA1c, smoking habit are going to be the reliable screening tools for periodontitis in a primary medical care settings. Moving on, that's an 1 second. Now what has happened? Okay. The periodontitis, that's another review paper we guys had published last 2 years back. Now that's an important study. The study took us about 1.5 years to complete. Why do I say 1.5 years? Because this again was a nature of the study was a knowledge and awareness study. However, this was exclusively in the sample of endocrinologists and diabetologists. This is a link to that study. Let us see what the study has talking about. This was a study of about 200 odd endocrinologists who were both satisfied. Let us see what were the results of this study. The response rate was pretty encouraging, 90.3%. Let us see what was the discouraging component. Let me go with the encouraging component first. So 85% of the participants agreed that oral health is necessary for overall health and general health. 65% were in favor of bidirectional referrals. 58% were in favor of inclusion of patients' oral health records in diabetic health history assessments. 80% respondents, that's brilliant. They said that collaborative training is important for medical and dental students in their educational curriculum in India. So what is discouraging about it? Look at this number. It's only about 11% respondents referred the patients for dental examination. That's not good. This should definitely get into these categories of at least 50% in the times to come. That's where the challenge comes here. Let us conclude. What did this say about from our paper? Awareness about the diseases. The bidirectional relation is pretty high among the study participants from our study. However, did not translate to the same kind in terms of the referral rate to the dental office. What does it tell us? We need to have integrated collaborative approaches amongst the two parties. When designing the protocols, there has to be an openness to share the patients to begin with. Such collaborations will be easy and helpful for us to early detection of the diabetic patients at periodontal risk. How we'll do that? A pre-diabetic screening to begin with, and vice versa. Now let me share, what am I trying to share here is, we keep hopping now. Let us talk about this person who is apparently a Diabetes India Secretary and a Vice President Diabetes Asia. Let us hear this video from him. Let us see what he has to say.
Cannot hear, ma'am, what he's speaking.
Oh.
You would have to like share with the audio kind of. Maybe you can just tell what otherwise.
So basically what he is telling is, I was really happy to hear from his end was, he has for the past 10 years has an independent dental setup in his clinical practice to begin with. He has a full-time dentist in his practice. He advocates dental setups for his fellow colleagues in the country. He advocates, if not a dental setup, he advocates for dental referrals. This coming from such people is a very encouraging note. And believe me, such I mean, we were just talking over. He himself said that today in India, there are only about a hand count of about 10 to 15, clinical practices in diabetology. I'm talking about the private setups, not the hospital setups, who have dental units of their own in India. And that's quite heartening. And this group that we have created somewhere goes down the line on boiling out this. Anyway, let us skip this video. So and come on to the directives and challenges. What is this directives and challenges talking about? To begin with, we need to have public awareness modules through public meetings. It could be through the print and digital platforms in India. It is already started from Government of India, the National Oral Health Programs. They have started with the smoking, and probably in the times to come, we should see some sort of digital platforms to be evolving. We have the IDA doing that. We have this Colgate doing that. So some sort of a print digital platform should come out and reach out the masses. Incorporation of dental and oral health screening. Again, I will share one small note. Apart from the dental setups, the endocrinologists, which I'm seeing at least in this Delhi belt, most of them have already incorporated dental screening performers in their particular setups. They don't do it themselves. However, they refer them out. An initial component of screening, as we are talking about the visual scale or analysis, they are doing it. So this should become a regular part of the practice whenever the diabetic patient is coming. And same thing applies to us. We as dentists, we have to scroll and proll the diabetic history for the patients who are suffering from periodontitis. Collaborative clinical research studies is the miles to go on the subject. We should encourage cross referrals among the medical and dental professions. Policymakers, let's see how much they hear us, but at least the baton should go on in terms of incorporating the oral health integration and making it an essential dream in the non-communicable disease section in India. Data collection, which is really crucial across all the dental and diabetic practices, should be initiated to ascertain the overall health and the economic burden posed by the periodontal disease and diabetes. Training the diabetologists, not a very happy thing to hear, but yes, many of them have really coming forward to why don't we organize some sort of a CMEs on this, where we give a small lectures upon how do we educate the diabetologist in terms of visual analysis, and further on, educate the diabetes educators and nurse practitioners. They are the very, you can say the left hands to all the diabetologists. They do all the counseling and the education rather than the doctor himself. And finally, incorporation of the importance of oral health in the UG and PG curriculum. PG curriculum, if not at least the UG curriculum of the medical and dental education should be there in the times to come. So with this, I would like to conclude collaborations and interdisciplinary or transdisciplines, whatever we say. This is the need of the hour. We all cannot do anything on our own. So let's just shake hands, mobilize ourselves, and move forward before we halt. With this, I would like to sign off and thank you so much, JSS, and extremely sorry for this technical glitch. We had to wait for its time, and thank you so much for your patient hearing. Over to you, Dr. Anita.
I think there are a couple of questions, Dr. Bennett.
Yeah, I will be I'll have a look. So thank you, ma'am, for that fantastic presentation. It was really an eye-opener. It's really fantastic to see how you have spearheaded the movement, and to see that a lot of medical practitioners are also thinking about taking up, the role and importance of the oral health. So that is really very, nice to see, and very happy to hear about it, being a fellow periodontist. So there are a couple of questions, ma'am, which I would just like to. So one of the questions is, madam, is there any strict cutoff value for fasting blood sugar, PPBS, and HbA1c? Like for starting a non-surgical therapy, you do this, and surgical therapy, like that. Anything which you can just throw some light.
See, basically, the HbA1c levels have been getting revised over the years. So the recent, which was released in 2020, if I'm correctly placing, that's what was shared, one of the endocrinologists, they have revamped the Asian cutoff. They say that 5.7 is the minimum line that we have to take, and 6.1 they have said is the diabetic range. Now they have started, ever since India is the diabetic capital for the worldwide information. So they have kind of, re-zero it down to, I think 5.7 to begin with is a pre-diabetic range they are now beginning to.
Okay. Okay.
Or any type of a work that they pick up as.
Okay. And also some question on gestational diabetes and periodontal disease. Can you throw some light on that, ma'am?
See, pregnancy, I mean, there's a lot of work that is going on and our fellow colleagues are doing a lot of work. So when we're talking about the diabetic management for a periodontal patient, broad line, it goes the same. Your control of HbA1c has to be there, be it any person. And yes, checking on the levels before the procedure is mandatory. And that is why it comes a picture of your glucometers in your setups. So important, because HbA1c patients are reluctant. They take a check and they not come across again. So checking it across prior to your procedures, before we plan it, and discussing it across with your physician, whosoever is attending it, is important, because that's what we are doing it on a regular basis now, whosoever is coming. That's a basic tool that we have to adopt. Share the patient, talk to the physicians, get the control levels into picture, and then mobilize your work.
Okay. Yes, thank you, madam, for that. I guess we have almost covered the question. Okay, there's one more. Can a periodontal abscess as such, like cause a high blood sugar, to shoot up the blood sugar or something because of the inflammatory cascade or something which you explained in the beginning? Your views, ma'am.
Yeah, basically isolated, definitely not, because already there's a host of inflammation going on in your body. Isolated will not, but yeah, multiple, they do complement, keep on adding to that whole gamut which is sitting. Not single one. Yeah, definitely not.
Okay. So thank you very much, ma'am. And I think we have come to the end of the question and answers too. Dr. Anita, anything else you would like to add, or
Nothing. Apart from the technical glitches, which was totally covered by.
It's okay, ma'am.
Your talk totally covered the glitches. They were
yes,
almost as
they masked them all.
Yeah, it was.
I would say you prepared the 100%, and something has to happen. That something was today. I was like
no, ma'am. Your talk pretty much covered entirely the glitches, and it was nothing to do with you, rather. As you were telling, in-house diabetes dental co-clinics or collaborations is vital. This is what we also felt here in JSS, and we do have a physician on board in our SIG team too.
Right.
And the interdisciplinary approach is very vital, and research regarding the glycemic status post periodontal therapy is also vital.
Right.
So I think I will ask Dr. Bennett to
give this some after the certificate file. Just
thank you, Dr. Sangeeta, ma'am.
Thank you so much, Anita, ma'am. Thank you so much, and I'm really heartening. I mean, India is rising. If I see the specialty groups coming up, that's how the awareness is going up. I mean, that's what I must congratulate you all for this.
The knowledge was invaluable to all the people, delegates apart, because not many of them left in spite of the glitches. And I don't think glitches was a major issue at all, ma'am.
Keep learning. COVID has given us this beautiful tool to keep learning with the technology and keep understanding the glitches.
Totally agree with you.
Yeah.
Okay.
Thank you, ma'am. Thank you for gracing and being part of us.
Thank you, Dr. Bennett. Thank you,
Bennett.
I've met you after a long time.
Yes, ma'am. Thank you so much for accepting and being a part of this learning experience.
My pleasure. It was extremely an honor for me. Thank you so much.
So with that, I think with these two fantastic, lectures and webinars, one from the Malaysian perspective. In fact, I'll just throw some light. In fact, in an article which came in the Star newspaper in Malaysia in 2018 in July, actually said that Malaysia is the diabetes capital of Asia. Oh. And, which caught this. And there was a fantastic article by a dentist on the amount of sugar.
Oh, okay.
And we have, calculated, like in this drink, Coca-Cola, how much sugar, how many teaspoons of sugar. Right. And we actually found that all this is actually having lesser sugar than compared to our, the iced tea and all these others, which have much more, the Maaza and all these, which have much more sugar, not the Pepsi and the Coca-Cola, which has. I mean, we have that, and the students do a project on that, and they have presented here also.
In fact, Dr. Ratna's one of the studies, I think, though they had undertaken it, was mentioning amongst the communities. And I think Indian community was like 31%. And that was quite alarming.
Yes.
Diabetes capital, though, Lord knows.
Everyone wants to compete.
No. That's something we should not be competitive with, but diabetes true. At least.
Yes. Yeah, so, and another important, nice take-home message which I liked in yours is you talked about the word transdisciplinary, and I was actually going to talk on that myself.
Yeah.
but you have spoken it so beautifully.
No,
So
please
I think,
let us hear from you, Dr. Bennett.
yeah, no, I like that approach. I mean, you have given a very beautiful definition of the same, and this SIG of JSS is just beautifully just that.
Right.
If you from last year they started off the project, and they had talks, undergraduates presenting papers, postgraduate, and more than that, even a dietitian, psychologist, things like that.
Lovely.
From last year this is happening, so I was involved as one of the judges, and many other people on the Perio team also.
Right.
And I felt this, and you know, it's really nice to see that we need this transdisciplinary model. So I really like that take-home message.
Even in hospitals, I've noticed these the people who have got the team, no, I mean diabetes care team. It's so heartening to see they have included dental care. It's so nice to see, you know, amongst the all foot care, podiometry, your eye, your everything. They include dental care in their manuals, and in these all they have started. I mean, the ones which are really well versed and well tuned, people have there done it.
I think we as dentists, ma'am, have you know, accepted and this because we study general medicine and general surgery.
Yeah,
I think the medical curriculum, as you very rightly said, they should have something on this, you know, the oral, you know, not just when they just come for some small visit in between when they are in year 1, I think, or 2, they just come, what is dental tooth anatomy and stuff like that. But I think they need a little bit more like how we really do this general medicine and general, and that is a very right model.
Even at the symposium now, Dr. Bennett, the type of, I mean, wish I could share the recordings, the type of experiences they were sharing now, it's what's very heartening. We were always focused on diabetes. We never thought that this was important. No wonder they had crossed it many times. They never bothered. So that's to keep on learning from each other.
So that is the like a very nice take-home messages. And actually, there's an article which states that severe periodontitis is the 6th most prevalent disease, which affects 11.2% of adults. And another take-home, another thing as I was reading through is that now, you know, that our link with the P. gingivalis, our foe or friend, I don't know, whatever you may call it, a two-edged sword. So, you know that because of the gingy pains, it has been linked to Alzheimer's disease. And then we again step in and we say that Alzheimer's disease has now been called as the type 3 diabetes mellitus.
Very true.
Yeah, and Madam very rightly, beautifully mentioned that, you know, the 57 Prof. Ratna, she mentioned about the 57 systemic which have been associated. So for this, I have that caption called as, you know, this Heinz ketchup, they have a number 57 on that. So that's how I, so that's how I tell my students that, you know, you have around 57 diseases which are associated with this. It's not just about this. And I mean, it's not like a cause and effect, but it is definitely associated with the same.
Very true.
And very beautifully, you told about the important role of a dentist in pre-diabetes mellitus, which is very important because they found that 9.9% of the people are unaware dental patients, especially, of course, in countries like in Sweden, 28% in the US, 46% in the Dutch, you know, so it's such, and this is the place if we can intervene, we can prevent them to become diabetes and, you know, lifelong dependent on this.
Absolutely.
So prevention always is better than cure.
Absolutely.
And a last point, which I just want to say is we have now incorporated, like, especially in Malaysia, the 2017, which was published in 2018 periodontal classification. And when we're talking about that, we have, we know that for diabetes, if the glycated hemoglobin levels is below 7%, he's a grade B. And if it increases, so it is also now embodied into the thing. Whereas in the older classification, we didn't really have that. We'll call that as chronic diabetes patient with a with involvement with systemic in bracket diabetes kind of a situation. So, and how you rightly said about the age, you know, the ethnicity, as Prof. Ratna mentioned. So all these things are important in the new classification also, and we are following this very much. So thank you both, Prof. Ratna and Prof. Sangeeta ma'am, for your fantabulous delivery of webinar.
It was a pleasure being a part of this whole show.
Over to you, Dr. Anita.
Thank you, Dr. Bennett, for that wonderful wind-up. He's rightly said about the transdisciplinary and our interdisciplinary approach that we're doing in JSS. It was a proud moment to have both all three of you together to join us and put up this particular topic for enriching knowledge for all of us. Yes, some physicians have joined today's talk, and it is really heartening, as ma'am says, to actually have physicians recognizing us
Very
and
important,
allowing us.
because,
Yes, ma'am, allowing us to
clinical
thrive.
level, we have to reach the clinical level. Bottom line, everything is fine. It's in the
Yeah.
clinical level we have to really tap.
Yeah.
That's where all these efforts go for, you know.
Yes,
how it
so we are undertaking research at JSSDC&H here, and our department especially has given enormous scope for PGs or UGs or faculty to
Right.
move towards that interdisciplinary thoughts or research.
Right.
Thank you so much, ma'am, Sangeeta ma'am, Ratna ma'am, and
Thank
Dr.
you.
Bennett
Thank you.
for being here and being a part of us. Thank you.
Thank you
Thank
so
you,
much.
thank you.
Thank you. Okay. Okay. Bye-bye.
Bye-bye.
Bye.
I think we wind up this session with this.
Yeah.
Thank you all
Okay.
delegates.
Thank you so
being here.
much.
Thank
Take care.
you. Bye.
Take care. Bye.
Thank you.
Bye.
Bye.
Thank you. Bye.